If you've been following along, my name is Dr. Jared Bonaquisti. I'm a physical therapist with Kinetic Physical Therapy, and we've done some of these lectures in the past, shoulder pathologies, different things, but today we're going to be focused on labral tears. So the objectives for today is we're going to learn about the bony anatomy of the shoulder girdle, learn about the musculature of the shoulder girdle, right, that affects stability, learn about the anatomy of the labrum, review the different types of labral injuries, and then look into some research that reflects best practice in treatment. So first, going over the anatomy of the shoulder, we're going to look first at the bony anatomy here. So we have the glenohumeral joint, which is right here, which is the connection between the head of the humerus and the glenoid fossa. We have the AC joint here, right, which is the connection between the acromion, which is this bone, and the clavicle. Then we have, on the back side, you have, we'll just take a bigger image here of the scapula. So these two move in unison to create any upward rotation, right? Reaching, grabbing, anywhere where your arm needs to go, these two have to work in unison. Now, if we start to throw some muscles on top of that, right, now we're looking at the rotator cuff muscle. So if you remember from last week, we did rotator cuff tendinitis and we did rotator cuff tears. So quick review of the rotator cuff muscles. We've got the subscapularis muscle, which is this big, thick muscle on the underside of the scapula. Then on the posterior side, we have the supraspinatus, infraspinatus, and teres minor. And those are the four rotator cuff muscles that work together to move the arm and help create that stability. So anatomy of the shoulder girdle. Right now we're taking a kind of a step back and we're looking at all the other muscle groups that attach in here. So here we have the posterior shoulder. We have all the musculature, supraspinatus, right? The infraspinatus, that teres minor, teres major, which is underneath here, which helps create internal rotation. And then you have your rhomboid muscles, which connect the spine to the shoulder blade. You have the levator scapula, which attaches to the superior angle and runs up, attaches onto the transverse process of the spine. You have your lat dorsi muscle, which is this big muscle here, which grabs onto the front side of the shoulder. And then you have muscles on the arm, like your triceps and biceps, which again all connect up into the shoulder here. So, looking at the musculature here, you can see that there's a lot of different muscle groups, and that's just on the underneath side. Then you have your upper trap, your middle trap, and lower trap, right, which also attach and help to move the shoulder. So you're looking at a lot of different muscle groups that need to work in unison, right, to create any sort of motion that you have, whether that be lifting up overhead, grabbing something heavy off the top shelf, holding a child, playing any sort of sports. You need that unison to work properly. And what can happen is if these aren't working in unison or you have weaknesses in some area over others, you can start to create a lot of wear and tear on the labrum, which brings us into some of the injuries you can occur. So looking at the anatomy, right? So what is the labrum? The glenoid labrum, right? You have a labrum in your hip and a labrum in your shoulder. So the glenoid labrum in the shoulder is a triangular shaped piece of fibrocartilage that is designed to deepen the glenoid fossa. It assists with creating stability for the shoulder and has connections with other structures, which makes labral tears complicated. So if we take a look right here, we have the capsule that surrounds the shoulder. You have the glenoid cavity, which is where the bone is on the scapula, and then you have this labrum here. So if you think about it, you can't have bone that wraps all the way around your shoulder to create stability, because otherwise you wouldn't be able to move at all. But the body's designed to have this triangular fibrocartilage that runs all the way around and kind of reaches out and kind of helps to keep that that humeral head in that glenoid fossa there. Again, it's only for stability. It doesn't have a good blood supply, which makes it difficult also when injuries occur, because they can't heal as quickly if they're able to heal. So here are the common types of labral tears that we see. You have Bankart lesions, right, which is a tear of the anterior labrum. You have inferior lesions, right, associated with a lot of instability. And then you have slap tears, or slap lesions, which means superior lesion, anterior to posterior. So you have that entire rip of the superior aspect of the labrum there. We see this a lot in athletes who participate in overhead type of activities. More uncommon ones, you can have what's called a Hill-Sachs lesion, which is actually a posterior tear, and sometimes that can also occur with glenohumeral dysfunction, instability, and also the humeral head can then be jammed and have a compact fracture associated with that. Again, that's a more like a posterior dislocation and a posterior labral tear. So the big one, slap tears, right? So let's go through the types of slap tears that you can have. Types 1 through 4, ranging from fraying of the superior labrum to bucket handle tear extending into the bicep tendon, and then a partial detachment of that bicep anchor. So if you look at number 1 here, right, everything's still intact. You just have some fraying, can definitely be repaired, or you can go through life with that and still function at a high level. Then it gets a little bit more intense, type 2, bucket handle type 3, and then type 4 is that most severe case there. So what does the research show? So we looked at a few research articles here looking at the difference between sham surgery versus labral repairs. And then, so if we look at this study, right, they focused on a 3-armed randomized approach to test the significance of two types of surgeries commonly performed with slap tears. The researchers found no significant difference between groups at baseline, 6 or 24 months, and the researchers noted that the present study does not support either labral repair or biceps tenodesis, which is taking the bicep tendon, which runs into the labrum, taking that off and moving it to a different space for type 2 slap lesions in this population. And I believe the population that they had was they weren't looking at athletes, they were looking at older individuals with that. They also noted that the results show a possible over-treatment of slap lesions and indicate a need to narrow indications for surgery. So we feel like just because you have a slap tear as an older adult doesn't necessarily mean you have to get surgery for it. We feel like this is the first thing we have to jump into the moment we figure a tear. The same thing happens with rotator cuff tears as well, but really we need to take a second look to see if that's really the indication that we should go with right away. Another article here looked at outcomes following arthroscopic repair. Right? So this is after a posterior labral tear, patients older than 35 years old, and they're trying to follow up, okay, these people went through with the surgery, and let's see what the results were. So the study focused on posterior labral repairs, right, older than 35 years old. The results of the study showed that posterior labral repair for patients at or over 35 years of age had more variable and worse outcomes than those reported of younger athletes. And that's what we see with slap tears there as well. So posterior labral tears and slap tears, we see those same sort of results. It's very variable. Some people respond very well, and then some people don't respond really well and have dysfunctions that go down the road. The author stated that the findings of the current study indicate that outcomes are generally less satisfactory than those previously described for arthroscopic repair of a reverse Bankart lesion, also known as a Hill-Sachs lesion, with or without instability. In this article, they also noted that 2 of the subjects, after going through this, actually had to get shoulder replacements because of the pain got so bad. Their dysfunction occurred and they had a lot of loss of functionality at home, so they had to go back and get shoulder replacements there as well. So those are some of those poor outcomes that you can see. Now, conservative management, right? It's the big thing we want to know. How can physical therapy help? But there is actually a lack of evidence investigating the efficacy of rehab for this condition. So we're not really sure kind of like what is the best practice. What can we do to improve on this? What can we do to improve on this injury? There were treatment recommendations focused around restoring range of motion, strength, and functional mobility. Rotator cuff exercises are recommended to increase shoulder joint stability, and patient education should also be implemented to correct any faulty technique, training errors, and sport skill training. So, I mean, this is the recommendation here, right? Again, there's no set plan that's been researched and shown to be like, hey, if you do these 10 things, you will be fine. But a lot of emphasis, and we keep seeing this over and over again in the research, exercise, right? Rotator cuff strengthening, scapular strengthening. Those exercises are what's being shown to improve people's function the most. Restoring range of motion, right? Using manual therapies to kind of, if that's tight joint mobility, if you're having some sort of capsular problem post labral injury, right, because of the inactivity, that's when manual therapy can really be implemented to help. We talk about strength training, right? We already talked about rotator cuff, scapular stability, and then functional mobility, right? Verbal cueing and hands-on techniques to improve that glenohumeral rhythm there, to improve that scapular, thoracic rhythm. Those are all ways that physical therapy can help support. And with the research showing that surgery doesn't really have the greatest outcome, this is a way that you can start off. Let's get this thing underway. Let's see if we can improve on the function. And then the surgery option is always there if it's needed. So, like always, right, if you need help or you need any more information or are looking for information, please contact Kinetic Physical Therapy or any physical therapist that you've seen before that you feel comfortable with. That's the biggest thing. It doesn't have to be with Kinetic. We would like you to reach out if you need something, but really we just want to promote conservative management. We want to promote physical therapy first because research continues to show that exercise, manual therapy is proving to be a better option than surgery. It's more cost effective, it's less time out of work, it's less time with physical restrictions on you, so it's definitely the best option to go forward. You can reach out to me. There is our phone number and my email address, and then we also have our social media page. Please check us out on any of those pages there. We would love to help out where we can.